those kind words, and thanks Dr. Bansi for having me part of this very prestigious meeting year after year. Task he is assigned to me is to speak on diabetes prevention from studies to what is a clinical implication. The flow of my session will be to summarize landmark randomized trials which have proven that prevention of type 2 diabetes is possible today. Then to show you the long-term follow-ups and the real-world national programs which have been adopted based on these landmark trials, and towards the end highlight implications for practice and what are going to be the public health scale-up. So let's see how we talk about prevention of type 2 diabetes, and based on that prevention strategies have been evaluated. Initially with intensive lifestyle modification. Earlier all trials they focused on lifestyle modification, aiming for significant weight loss, diet and physical activity. Subsequently then there were trials which were based on pharmacological intervention, which were primarily metformin, acarbose, TZs and now GLP-1 receptor agonists, and the implementation models for that have been either individuals or groups or cohorts or a telephonic contact, maybe digital model, and lot of apps have been used for prevention strategies. When it comes to diabetes prevention trials and intervention, we know that there is going to be a relative risk reduction across all these trials, whether these are lifestyle trials, pharmacological trials or surgical approaches. And why we have picked up the model of diabetes prevention, it is very, very important to understand that pre-diabetes is a very, very known established entity, that is one. It carries a very high risk per se, even if it does not get converted to development of type 2 diabetes, and early intervention at the stage of pre-diabetes can significantly reduce progression of the disease towards type 2 diabetes. And there are evidences from both pharmacological, lifestyle and surgical trials that this is a preventable entity, that if we intervene at the stage of pre-diabetes, we can prevent onset of type 2 diabetes. The various trials in general, when it comes to lifestyle, have led to almost 40 to 50% reduction. Pharmacotherapy have been very, very effective, especially with GLP-1 receptor agonists now playing, it could be as effective as 90%. And surgery, of course, gastric bypass surgeries and various options have also led to prevention of diabetes almost to the tune of about 80%. The earliest prevention study, which came from China as early as 1986, and it was carried for almost 4 years, dumping diabetes prevention study, which was and it had a long-term follow-up. This was designed as a cluster randomized by clinics, and participants they had impaired glucose tolerance. Intervention was in the form of diet, exercise, or diet plus exercise versus control, and the key results, some were that there is going to be a reduced progression to type 2 diabetes with long-term follow-up, which delays onset of type 2 diabetes, and benefits could last as long as 20 to 30 years. And this is the design and the results, that there was a relative risk reduction. We don't have a pointer here. Okay. There is a relative risk reduction between the control and the intervention arm by at least 31%, and these patients, they have been subsequently followed over 25 years also. This 6-year cumulative incidence led to a reduce when you saw the control group, there was a conversion by 41%, and in the intervention arm, which had intensive lifestyle, was a reduction, and there was a 28% conversion to type 2 diabetes. So the relative risk reduction was to the tune of 31%, and this trial was well lasted for 3.6 years. But I told you there is a follow-up data which is available till 25 to 30 years. Another finish. How does it go? No. Okay, it's all right. Then there was a Finnish diabetes prevention study, which again was carried out for almost 4 years. it was designed like a randomized controlled trial of intensive lifestyle counseling in individuals with IGT. The target was a weight reduction, a dietary fat reduction, an increased fiber intake, and a increased physical activity. The key results were again that there was a 58% relative risk reduction versus the control arm, and benefits again lasted in the follow-up. This is how the results were published, that versus the control arm, in the intervention arm there was a 58% reduction in risk of developing type 2 diabetes, and this has been a benchmark trial in terms of prevention, especially with lifestyle modification. A trial lasting for 3.2 years. In the control group, there was a conversion by 23% versus the intensive lifestyle arm, where there was a conversion by 11% and a relative risk reduction of 58%. And this effect again lasted almost for 10 years in the subsequent follow-up. Then there was another trial which was almost on the same model, diabetes prevention program carried out in US. Again, almost 4 years data. It was a multi-centric trial with patients, those who were having IGT or IFG, and they were again compared in terms of lifestyle adoption, metformin versus the placebo arm. Here the aim was to achieve at least 7% weight loss and a physical activity of 150 minutes per week, which was recommended and followed in this trial. The key result was that lifestyle reduced incidence by 58% versus the placebo arm, while metformin reduced it by only 31%, and the benefits lasted in the diabetes prevention program outcome study, which is a follow-up of almost 21 years of the same study. And in this study, if you see the three arms, control versus lifestyle arm versus the metformin arm, you could see that there was a conversion in the placebo arm to type 2 diabetes in 11%, in the metformin arm it was 7.8%, and in the lifestyle arm it was 4.8%. So lifestyle scored over all other modalities, whether it was metformin or the placebo arm. So overall there was a reduction in conversion to type 2 diabetes from IFG or IGT by 58%, and benefits again have persisted in the follow-up trial outcome study, that is DPP outcome study OS follow-up. Then came Indian Diabetes Prevention Program, both 1 and 2. This was carried out by Dr. Ramachandran from Chennai. It was randomization in Asian Indian subjects with IGT. Intervention was in the form of lifestyle modification, metformin, or a combination of both, and it was a community focus adoption in this trial. The key results was again that lifestyle modification and metformin reduced the progression, which came out to be very, very cost effective, and it was followed very well. In this trial again you could see that in the control arm there was a conversion to type 2 diabetes by 55%. So there is a saying that 50% of your patient will in any case convert to type 2 diabetes over 5 years on an average. Lifestyle adoption reduced it, but it was still 39% patient be converted to type 2 diabetes. Metformin also had a conversion of 40%, and even if lifestyle with metformin was combined together, combination also had a conversion to type 2 diabetes in 39% of patients. So the 3-year diabetes incidence in the control arm, lifestyle and metformin arm, once compared, it was found that the combination of metformin and lifestyle reduced the conversion to type 2 diabetes by almost 28%. Another trial that was Japan did, and other regional trials also subsequently came on the same model of DPP trials, and these were sort of multiple countries trials and primary care trials also in Australia. That was Australia GGT, then DPP and LIFE program also. In the Japan trial, it was again seen that there is going to be relative risk reduction to type 2 diabetes from IGT or IFG by 48%, and the 4-year incidence in the control arm was 18% versus 9% in the intervention arm. So almost 50% reduction simply by lifestyle modification. So to sum it up in a master chart, all diabetes prevention trials, whether earlier the earliest one doping, Finnish diabetes or US DPP or Indian DPP or the JDOIT, almost 58% reduction in conversion to type 2 diabetes in the lifestyle arm versus the drug. In the metformin it was 31%. So even if you introduce a drug, possibly lifestyle will go a longer way in prevention of all these conversion to type 2 diabetes. So based on that, large national and large scale implementation programs have been started. In UK it was NHS Healthier You Diabetes Prevention Program, which has shown reduction in incidence conversion to type 2 diabetes, the Australia Life trial, and Greater Green Triangle DPP trial again, which was a community trial. Australian Lifestyle Intervention Program has shown, which was titled as Greater Green Triangle DPP, has shown a relative risk reduction by 40%, and Life Program Victoria, which was a community-based behavioral intervention, has shown a relative risk reduction by almost 34%. Then various US community programs have also been started on the same model. YMCA Diabetes Prevention Program, which successfully adapted the original DPP intensive lifestyle intervention for widespread community implementation. It was a structured curriculum with 16 sessions, core program followed by a monthly maintenance session, and this was a group-based delivery model fostering accountability and shared motivation among participants. So the clinical outcome was that there was a 34% diabetes risk reduction achieved through community-based lifestyle modification approach, which was very, very significant. Various meta-analysis and evidence have shown that there are consistent findings that intensive lifestyle modification or intervention probably have gone best in terms of prevention of type 2 diabetes from pre-diabetes, and it is primarily the weight loss which predicts the benefits in terms of relative risk reduction. Then coming to the drugs or pharmacotherapy for prevention of diabetes from IGT, stop NIDM trial, which was with A corpus, has shown that impaired glucose tolerance patient, if they are subjected to A corpus therapy, there could be a 25% reduction in conversion to type 2 diabetes. But TZs have been very, very impressive. Tripod trial with rosiglitazone has shown a reduction by 75%. DREAM trial has shown with rosiglitazone a relative risk reduction by 60% on 8 milligram daily for clearly substantially reduced incidence of diabetes. But it is always questionable whether you are treating it like diabetes with a drug like TZ, which is a sensitizer, which could also be used when, say, your HbA1c is 6.5 or 6.6 along with metformin. And similarly, pioglitazone has also shown in ACT-NOW trial that there could be a relative reduction by 72%. Another trials which are cardiovascular drugs efficacy trial, Navigator trial, which has investigated a dual benefit both in cardiovascular metabolic benefits, has again shown that valsartan ARB therapy could reduce the conversion of type 2 diabetes from pre-diabetes by 14%, and even magnetide has been used, but results with magnetides in diabetes prevention were not very, very impressive. But GLP-1 has, the receptor agonist has come out to be a breakthrough. Tirzepatide has demonstrated a unprecedented almost 94% reduction in diabetes progression across all doses in individuals with pre-diabetes and obesity. So today, if we talk of pharmacotherapy after lifestyle modification or along with lifestyle modification, I think it will be ultimately the use of GLP, which will go a long way because you have all the benefits coming from that. Weight management interventions have been already targeted even with orlistat, some relative risk reduction almost to the tune of 37%, but bariatric surgery that way has been most impressive in preventing conversion from pre-diabetes to diabetes in all those patients, those who have either obesity alone with a BMI more than 32.5 or with comorbidities in Asian or Indian patient even at a BMI of 27.5. So when it comes to the final efficacy analysis, GLP could get a prevention or relative risk reduction by 94%. Bariatric surgery could get in different forms of bariatric surgery up to 80%. TZs, I told you, troglitazone has shown 75% relative risk reduction, pioglitazone 60%, rosiglitazone 72%, and lifestyle, which have been seen in all DPP trials, has shown a relative risk reduction by almost 58%. But when it finally comes to clinical and public health implication, I think we need to screen high-risk adults, all patients, irrespective of their age, if they have a higher BMI, have a family history, ethnicity, or have IFG or IGT, when proven with HbA1c, they must be offered this lifestyle modification, at least lifestyle modification for every patient to prevent conversion to type 2 diabetes, maybe along with either metformin or GLP-1 receptor agonists, which have proven value in terms of additional benefit of relative risk reduction to type 2 diabetes. And it models could be either a group, or it could be a telephonic or a app based or a digital for scaling and monitor, of course, comes in form of long-term equity. So the clinical implementation considerations are, when you talk about evidence hierarchy, GLP-1 receptor agonists and bariatric surgery are probably best in terms of prevention of diabetes. When it comes to population health impact, lifestyle intervention are possibly the best option, because you might not be able to offer drugs like GLP-1 receptor agonists to every patient across larger population. So lifestyle modification with benefit or evidence in form of 58% relative risk reduction possibly is a true model for third world countries and like ours. And future directions are that combination therapies and personalized prevention approaches, which could be based on genetic and metabolic profiling of the patient along with their risk, which can be calculated, and then they can be, of course, offered drugs like GLP-1 receptor agonists, maybe other than metformin. Thank you very much for your patience listening.